Welcome to today's ESNM GMFH webinar. First, let me introduce myself. My name is Eduardo Savarino, working at the University of Padua, Academic Hospital of Padua, and I'm leading here the program of FMD in patients with mainly C. diff infection, but also in trial, we are trying this method also in other patients like those with autism or like those with other kind of infection. Today, I'll be responsible for hosting this webinar, and I'm glad to welcome Professor Daniele Roberto Giacobbe from University of Genoa and Harry Sokol from Saint Antoine Hospital of Paris, who are experts in the field of Clostridium difficile infection, but also more in general, microbiota and infectious disease. Before we get started, I'd like to go over a few items so you know how to participate in today's events. First, I would like to thank you, Ferring Pharmaceuticals, for supporting the ESNM GMFH webinar series 2022, but also I will thank them at the end of this webinar. As to the control panel, we have taken some screenshots of an example of the attendees control panel. You should find it at the bottom of your computer, desktop, or cell phone. You are listening and using your computer speaker system by default. You will have the opportunity to submit test questions to today's panelists by typing your question into the Q&A box of the control panel. You may send in your question at any time during the presentation. We will collect them and address them during the Q&A session at the end of today's webinar. Interaction is really important for webinars. You know that since the outbreak of COVID, so please make lots of questions to our speaker. I have to let you know that the first talk will be recorded, so we will not have the speaker at the present webinar, but it will be more happy if you can do the question, and it will answer afterwards separately to each of you who will do the question. On the other hand, we will have Harry, Professor Sokol, for all the whole duration of the webinar. So please make lots of questions for him that he will be happy to answer live ongoing. As to the chat function, we have also this. The chat feature provides the ability to send instant messages during the session. And in case of problem, of course, if video is frozen or if there are audio issues, please do it. And also we have the polling. We have some questions during the Professor Sokol presentation, and you will have also the opportunity to answer to this polling. So I think that I finished to make all the stuff related to how to participate to this webinar. And again, thank you, Ferring Pharmaceutical, for supporting us. And I think that we can start with the first speaker. The first speaker is Daniele Giacobbe, is a specialist of infectious disease, is an expert of Clostridioides difficile infection and more in general on infection disease. He's from University of Genoa, and he will give his presentation on epidemiology and outcome of patients with Clostridioides difficile infection. Please.
Thank you so much for the opportunity to participate in this very interesting webinar series on C. difficile or C. diff infection. These are my disclosure, and C. diff was firstly recognized as the most frequent cause of antibiotic-associated diarrhea in 1978. And at the beginning, Clindamycin use was reported as the most frequent broad-spectrum antibiotic used in patients with CDI as a predisposing factor. However, almost all broad-spectrum antibiotics can cause CDI, can predispose to a C. diff infection. Indeed, in the subsequent years, from 1983 to 2003, the most frequently reported class of antibiotic previously administered to patients with CDI as a predisposing factor was cephalosporins, probably reflecting the increase in the use of cephalosporins during those years. Then, at the beginning of this century, an increase in the frequency and the incidence of CDI were reported from Canada, but not only from Canada, also from other parts of the world, like the US and Europe. For example, in a large study in a hospital in Canada in 2004, it was reported that the cumulative incidence of CDI increased from 3 to 12 per 1,000 persons in 1991 to 2002 to as much as 25 to 43 per 1,000 persons in the subsequent year. And as reported before, an increased frequency of CDI was concomitantly reported in other parts of the world like the US and Europe. At the same time, fluoroquinolones started to be reported as another important risk factor, predisposing factor to CDI. This may be due to the fact that the increased frequency of CDI in all those countries that we mentioned before was mostly due to an epidemic strain, the NAP1 or ribotype 027 strain, which is indeed resistant to fluoroquinolones. So these characteristics may have favored the spread of this epidemic strain, and also make clinicians and researchers able to recognize fluoroquinolones as an important risk factor for CDI, in addition to cephalosporins and clindamycin. But there are not only antibiotics as predisposing factor for CDI. Other predisposing factor is gastrosurgery, which is not reported in this slide, but also an advanced age. Indeed, the risk of developing CDI is 20 times higher in patients in patients older than 65 years old compared to patients younger than 20 years old. And hospitalization is also another important factor that predisposes to C. diff infection. Indeed, as soon as in the 80s and in the 90s, it was recognized that colonization by C. diff, which is the most important predisposing factor, because if you don't have colonization, you cannot develop CDI, C. diff infection. But colonization was observed in much more frequently in hospitalized patients compared to healthy adults. So this stresses the importance of infection control measures to prevent cross transmission between patients of C. diff colonization in hospitals and healthcare facilities. O27 will remain the most frequent, but its frequency has reduced over the years, and other ribotypes have started to appear. Now we can go back a few slides to the US epidemiology, and besides the hospital or care-associated CDI that was decreasing in the last few years, concomitantly an increase in the number of community-associated CDI was registered. And also community-associated CDI may be severe in some cases. Community-acquired or CI-CDI may be caused also by the ribotype 027, which spread easily and is is more virulent than other strain, but also there are other strains that have been reported as a cause of CA-CDI. For example, the O78 strain, which has also been isolated from animals. This is an important epidemiological link to understand the diffusion. The ribotype O78 has also been linked to a similar virulence and severity of clinical presentation in comparison to the report type O27. For translating from epidemiology to outcome, we need to speak about the recurrence of CDI. Recurrence of CDI is mostly defined as a novel CDI episode occurring within 8 weeks after the favorable resolution of a previous CDI episode. Although the definitions are different across studies in the literature, and we will see this important point in this next slide. However, I want to stress that recurrence of CDI is important both from epidemiology and for the outcome, because of course, recurrent CDI episodes are CDI episodes, so they are important for depicting the epidemiology. But recurrence of CDI is also a thing we do not want to occur, so it is an unfavorable outcome because it impacts unfavorably on the patient quality of life, on the patient health. It contributes to an increase in the length of hospital stay. It also poses the patient a risk of complication, as also the first episode. So it's both important for epidemiology, but it's also an outcome. Before see the heterogeneity in the reporting prevalence of recurrent CDI, I want to stress that the risk of developing a recurrent episode increases with each successive episode. This is, again, a study we conducted in Italy, a large multi-center study prospective in 15 Italian centers that was coordinated by Guido Granata and Professor Petrosillo from Rome, and we were able to provide a large estimate, a solid estimate of the cumulative incidence of recurrent CDI in Italy, which was 21% among almost 300 patients with at least one episode of previous CDI. And this rate is in line with the previously reported 10 to 30% recurrence of CDI, which is high, and this is important from clinical practice. But as anticipated before, and as you can see in the table on the left, the reported prevalence of recurrent CDI varied markedly across studies in the literature, ranging from 0 to 2% to almost 40% in some cases. Importantly, the different definition of recurrence provided in the different studies, which need standardization, likely contributed a lot to this heterogeneity. But of course, there are also clinical factors predisposing to recurrent CDI. For example, this is a table from a systematic review that guided the development of the guideline for the management of CDI by the European Society of Clinical Microbiology and Infectious Diseases that were released last year. And you can see that being older than 65 years old, having had the previous recurrence, having a hospital-acquired CDI episode, having previous hospitalization, and the use of proton pump inhibitor started during or after CDI diagnosis are factors that were consistently they consistently show a direction of the effect towards an increased risk of recurrent CDI in the different studies in the literature. So they are consistent. Effect was found in most studies. However, it is important to note that the quality of evidence for the association for recurrent CDI is low to moderate, only low to moderate. In this slide, you can also see that the same process was done from factors associated with severe CDI. Severe CDI is a clinical aspect. You will see this in other part of this webinar series that are dedicated to clinical presentation of CDI. But it is important, severity is also important for the outcome, because patients with severe CDI have an increased risk of complications like shock, like toxic megacolon, and then an increased risk of needing colectomy, and overall an impact on the mortality of CDI. So the heterogeneity in the definition not only of recurrence but also of severe CDI may also impact our estimates of the mortality attributable to CDI, and we will see this in the last few slides. Before discussing the heterogeneity in the mortality and the role of the definition of the severity of the disease, I want to stress that mortality reported in patients with CDI may be high. In a large Canadian study, multi-center Canadian studies conducted in 2009, the all-cause mortality, here it was a 30-day mortality, was as high as 15 to 23%, although we will see the heterogeneity in the next slide. But before moving to the next slide, which is the last slide of this presentation, I want to bring your attention to this table, which is taken from another study conducted in the Netherlands in 2003, published in 2013, that compared the mortality in a patient with CDI to the mortality in controls without diarrhea. And after adjusting for age, sex, and comorbidity and other prognostic factors, an independent effect on mortality was observed for the development of CDI. So, beside impacting on the quality of life, beside impacting on the length of stay, and beside impacting on the patient health in terms of less hard outcome, there is also an independent impact of CDI on mortality, which is independent from other factors. To conclude, the heterogeneity is also important in the rates of mortality of CDI reported in the literature. On the left, you can see the in-hospital mortality, which again ranges from less than 10% to more than 30%. And on the right, the attributable mortality, which ranges from 0% to more than 20%, so a large interval. And these reflect, of course, a difference in the definition, especially for attributable mortality, because in hospital mortality is more hard outcome to define, more easy to define. Although also the follow-up is important, because 30-day mortality cannot properly be compared with in-hospital mortality or long-term mortality. But contributing to this heterogeneity, and most importantly hampering a proper comparison between studies, is, in my opinion, the definition of severity, because the definition of severe CDI infection is impacting the registered prevalence of severe infection in the different studies, and then they are hardly comparable to understand the impact of severity on the outcome, and to understand in comparison to other settings, which are the most important preventive efforts to be implemented in any single center of hospital. And with this slide, I thank you for your attention.
I would like to thank Professor Giacoppi for his excellent presentation. As said before, unfortunately, he is not live, is not present at this webinar today, because he had something unfortunately to do. But please, if you have any question, we will take note of this question, and we will transmit the question to Professor Jacope, and I'm sure he will answer afterwards the meeting directly by email. Anyway, we heard really good, a really good presentation about the epidemiology of Clostridioides difficile infection and the impact on our clinical activity and clinical practice. We have now, and it's time now for our next speaker. The next speaker is Professor Harry Sokol. He is a professor in the gastroenterology department of the Saint Antoine Hospital in Paris, France. He's the co-director of the microbiota gut inflammation team and group leader in Michaelis Institute. He's an internationally recognized expert in IBD and in gut microbiota, publishing more than 250 papers on major journals. Currently, his work focuses on deciphering the gut microbiota host interaction in health and diseases to develop innovative treatment. Hope you will be able to do that, Harry. He's in the current president also of the French group of FMT, and we are looking to listen to him. He will give us a talk about IBD, inflammatory bowel disease, and IBS, irritable bowel syndrome, good patient for bad Clostridioides difficile infection. Please, Harry.
Thank you very much, Eduardo, for the kind introduction, and thank you to all of you who are online. So let's talk about IBD and a little bit about IBS in C. diff infection. So just first, I want to start with a reminder regarding the gut microbiota, just to set the scene, basically. So for an adult of 70 kilograms, you have approximately 2 kilograms of intestinal content. Of course, in this intestinal content, you don't have only microorganisms. There are plenty of things, including water. We estimate currently that we have the same number of bacteria in the gut than the number of cells in our body, so roughly 10 to the 13. And if you take 1 gram of stool, there are approximately 100 billions of microorganisms. In our cells, we have the human genome, as you know, which is, if everything is right, the same in all of our cells. If you put together all the genes present in one gut microbiota, one human gut microbiota, there are more than 25 human genomes in terms of information. So huge potential in our gut microbiota. In the microbiota, we have bacteria. At least this is the part we know the best. And in the colon, they are dominated by anaerobes belonging to these two major phyla, the Bacteroidetes and the Firmicutes. This is what I just mentioned. This is only introduction. So besides bacteria, we also know there are other types of microorganisms, particularly fungi and phages, but also archaea and protists. So what about Clostridioides difficile? So as you know, this is a gram-positive anaerobic spore-forming bacteria widely distributed in the environment. There are vegetative form, which are highly sensitive to oxygen, but also spore form, highly resistant. It is estimated that approximately 3% of the healthy adults are asymptomatic carrier, although it's probably an underestimation. You know also that this microorganism can be transmitted by fecal oral route, and that the condition to induce a C. difficile infection is an alteration of the intestinal microbiota, and most of the time this is in the case of antibiotic treatment. So what are the relations between C. difficile and IBS? So this will be particularly short. Basically, there is no higher risk of C. difficile infection in patients with irritable bowel syndrome. However, there is a risk of post-infectious IBS in the case of CDI. Unfortunately, we have very few studies evaluating this aspect, and there are in all these studies many methodological limitations. However, it is estimated that the risk of IBS after CDI would be between 4 and 20%. And very likely, although it has not been specifically studied, this risk is much higher in patients with multi-recurrence. of CDI. So now let's move to IBD, and you will see that there is much more to say about C. diff in IBD. So as you know, the pathogenesis of IBD is related to an activation of the GI immune system towards the gut microbiota in genetically susceptible hosts and under the influence of environmental factors. But in the last decades, there have been many data showing that indeed environmental factors and genetic factors can indeed impact the disease through an effect on the gut microbiota. It does not mean that everything goes through the microbiota in this disease, and other factors might impact the disease independently of the microbiota. So what is important is that the gut microbiota is altered in inflammatory bowel disease. On this figure, each dot represents the microbiota of one subject. And if two dots are close, it means that the microbiota are similar. And if two dots are far, it means that they are different. And as you can see, the blue dots here showing representing healthy subjects are different from the dots of patients in IBD flare, which are in red. And the patient with IBD in remission in green are basically in the middle. So there is an alteration in the microbiota, and what is also known is that there is a decreased diversity of the microbiota in patients with IBD compared to healthy subjects. And what does it mean? It means that there is a lower number of different species in the gut and an altered equilibrium between these species. To be more precise, what are the alterations in terms of composition? Here you can see on the healthy subjects that the microbiota is dominated by the two phyla I mentioned earlier, the Firmicutes in blue and the Bacteroidetes in green. And you can see that in IBD, there is a decrease in the Firmicutes phylum here in blue. And then you can see the bloom of this orange bacteria, which are belonging to the Proteobacteria phylum, and one of the major member of this phylum is Escherichia coli. So what about C. difficile and IBD? We know that IBD is a risk factor for C. difficile infection. Unfortunately, there is no specific recommendation until now regarding IBD in the different guidelines that have been published, including the ESNM. And we don't have good evidence from prospective studies. The only thing we know is that among patients hospitalized for IBD flare, having CDI is relatively frequent. It is up to 10% in this population. So this is why when we have a patient hospitalized for IBD flare, we always look for CDI. And this risk is higher in ulcerative colitis compared to Crohn's disease. So let's have a small case, which is a real one, actually. So it is a 37-year-old man with ulcerative colitis. You see, have been diagnosed 3 years ago. He has bronchiolitis with moderate lesions. He is treated with 5-AZA and azathioprine and nothing else. And in the last 3 weeks, he got a progressive apparition of gastrointestinal symptoms. And when you see it, he has 4 liquid stools a day, abdominal pain, and indeed he lost 3 kilograms, and his usual weight is 70 kilograms. So we did C. diff test, and we found that indeed he has C. diff infection with positive GDH and positive toxin also. He has some moderate anemia, high level of white blood cells, high CRP level at 43, low albumin at 29, liver and kidney tests are normal, and on the sigmoidoscopy you find marked erythema, a lack of vascular pattern, and friability and erosion, and you have here the picture actually. So I have a small question for you. What is your attitude regarding azathioprine in this case? And so I'm launching the poll, and you can vote here. So please do it. We'll take 15-20 seconds And then we stop the poll. Okay, maybe 2-3 more seconds. So usually in non-IBD subjects who have a healthy microbiota, you need antibiotics treatment to alter the gut microbiota, and this is mandatory to develop CDI infection, although now we see more and more healthy subjects getting C. diff without antibiotics. But globally, you need some kind of alteration of the microbiota. In IBD, there is, as I mentioned, at baseline already an alteration of the gut microbiota. So you do not need antibiotics or any other factor to elicit a C. diff infection. And what we also know is that the dysbiosis, the alteration of the gut microbiota, is correlated with inflammation and with relapse risk. So it means that CDI can indeed trigger IBD flare, but also that IBD flare can trigger a CDI. So basically, there is here a vicious circle between inflammation induced by IBD and the infection due to C. difficile. So what does it mean? It means that CDI in IBD reflects a poor disease control. For you, it should mean the underlying IBD is not well treated. So in this case, we should treat, of course, the CDI, but also the underlying IBD. And this is why, in this situation, you should not stop the immunosuppressive treatment. So second question, what are you going to do? What therapeutic option do you consider? So here again, I'm going to ask you. So you can answer this question. So what therapeutic option do you consider? Steroids, antibiotics, antibiotics plus steroids, anti-TNF alpha, antibiotics plus anti-TNF alpha, or surgery? And here again, we're going to wait a little bit more, so a few more seconds. So this is very good. You are many to vote, so thank you very much. Okay, let's stop. And here are the results. So most of you voted for antibiotics plus steroids, 31%, and antibiotics plus anti-TNF, 33%, and 21% for antibiotics. So most of you are actually globally right. So let's see. So of course, we should start with antibiotics in this case. First, before starting another immunosuppressant, we have to treat the C. diff infection. So first, we treat with antibiotics. We keep 5-ASA and azathioprine, and we do the pre-anti-TNF test, because obviously this is a treatment we might need in this patient. So what antibiotic are we going to use in this patient? So again, and this is the last question I have for you. Here it is. You can vote. What antibiotics are we going to use? Metronidazole, vancomycin, or fidaxomicin? So most of you are actually right. 64%, so 2/3 of you said vancomycin. So indeed, vancomycin is a good answer. Basically, we should not use any more metronidazole in CDI, except in some cases that in which we don't have access to any other drug. And in IBD, it has been observed in a retrospective study that particularly in ulcerative colitis, that vancomycin was associated with a better outcome than metronidazole, with a shorter hospital stay, so 6 days compared to almost 14 days, and also less frequent readmission, which is of course a major endpoint in this setting. So 0% with vancomycin compared to 31% with metronidazole. For fidaxomicin, until now, I think we have insufficient data in IBD. I think it's not forbidden to use it, but what we do, and my suggestion is to use vancomycin in this case. You have to remember that fidaxomicin, one of its advantage would be to decrease the alteration of the gut microbiota, but in IBD, the microbiota is already altered anyway. So here, as I explained, there is this vicious circle between the inflammation induced by IBD and the infection induced by C. diff. And so there is this two arms of the vicious circle, and we have to act on both of them. Antibiotics on C. diff infection and immunosuppression after antibiotics initiation on IBD flare. So what about fecal microbiota transplantation? So just to remind you that there is only one indication in routine clinical practice, which is recurrent C. diff infection after the second recurrence. So it means, so here you have the definition of a recurrence. You have first a first episode of CDI, which is efficiently treated. Then you have a free interval without symptoms, less than 8 weeks, and preferably with new antibiotic intakes. And then you have reappearance of diarrhea with C.difficile positive test, and this is a recurrence. And the indication, the current indication for FMT is after the second recurrence of the third episode. So what about FMT in recurrent C. diff infection in IBD? There are only few data. One multicentric international studies on 67 cases published 5 years ago. And in this study, the efficacy was almost at 80%. And there was also some effect on the underlying IBD with some kind of improvement in almost half of the patient, but you can see that you can also see some kind of worsening. Here it was noticed in 18% after FMT. A more recent study published this year on a European study on 105 patients reported an efficacy of 66.7%. And interestingly, the only factor associated with failure was the non-control of underlying IBD. So it really reinforced the message I sent you, which is to treat both the C. diff infection, but also the inflammatory bowel disease. And you can see here that after, you can see here the cumulative CDI-free survival, which is basically the same as in other cases. You can see that you have the recurrence quite early after the. So in conclusion, CDI, and particularly recurrent form, is a source of post-infectious IBS, although this is quite, I mean, it is not well documented, and the frequency is not well documented. The gut microbiota is altered in IBD, and it plays a role in the disease. CDI is very frequent in patients with IBD flare, and CDI should be tested in all cases of severe IBD flare and in case of re-aggravation after an initial response to treatment. And this is something we see very often. We have a patient hospitalized for an IBD flare. We start to treat him with some immunosuppressant or biologics, and there is improvement, and then a few days later there is a worsening again of the situation, and you have to test for C. diff in this case, and it's very often that we find C. diff in this setting. So CDI in a patient with IBD should be considered as a sign of poor control of the underlying IBD, and treatment of CDI in IBD patients should target, of course, C. diff, but also IBD after 2 to 3 days of antibiotic treatment. And as I showed you, FMT can be used in case of multi-recurrence, including in IBD case, and it has a good efficacy also in this setting. Thank you very much.
Thank you, very wonderful presentation. And we have time for some questions, and we have some questions. So
good.
Now is one is on the chat. Are there ongoing studies on probiotics or other treatment for CDI secondary prophylaxis in patients with IBD?
Not that I know of.
Is there any protocol at hospital? This is more in general for CDI infection. Is there any protocol at hospital for hospitalized elderly to minimize the risk of acquiring CDI infections during their hospital stay?
Not that I know. I mean, we have to focus on hygiene, of course, washing hands. Even today, we see some contamination between patients or with the nurses or the physicians. So we have to go back to the basic, avoid the useless alteration of the gut microbiota. So basically give antibiotics only if it's needed, and same for PPI. But besides that, at least from what I know, there is no primary prevention of CDI. So maybe, I don't know, maybe in some countries they are using probiotics. I don't know if in Italy, Eduardo, if you are doing that.
Yeah. You know that there are some studies from Italy with the use of VSL number 3. That probably that is one of the questions that has been done by one of the audience, one of the people who was listening to us. I mean, there are no robust evidence about its efficacy in preventing CDI infection. Is more, you know, most of this data come from studies done in a patient with pouchitis, and
Yes.
and so probably could be used, but cannot be suggested or advised by any guidelines or expert opinion paper. There is another question in the Q&A session. Could you elaborate a little bit more on the reason behind recurrent CDI? On the recurrence.
So, okay, so what is the pathogenesis of recurrent CDI? So there are many hypotheses, but the way I see it is this one. When you have CDI, we treat with antibiotics. So let's take vancomycin. So we basically shut down the level of C. diff in the gut. I do not think we completely eradicate it. We just decrease it massively. But the problem is that the surrounding microbiota is also altered by this antibiotic and also by the previous antibiotics the patient received. So we have a decrease in both C. diff and the surrounding normal gut microbiota. So when you stop the vancomycin, you have basically a kind of competition between the normal gut microbiota and C. diff. And unfortunately, for a first recidive recurrence, in 15 to 20% of the case, this is C. diff which is winning this competition, and then it's inducing a recurrence. And as you know, after a first recurrence, the risk of a new recurrence is even higher, around 40%.
Sure. Another question: are you use FMT after treatment or together with treatment? I suppose they.
So most of the time we are using FMT basically to prevent the recurrence. So we give vancomycin or fidaxomicin, but most of the time, if we are going to do FMT, we use vancomycin for at least 4 to 5 days, and then we stop vancomycin and we do the FMT. But in this case, in theory, the patient already responded to vancomycin. In some other case, which is a little bit less frequent and not as well documented, we use FMT in case there is an inappropriate response to antibiotic, meaning that the patient, despite antibiotic treatment, still have diarrhea, inflammatory syndrome, and so on.
There's another interesting question. Screening for C. diff colonization in otherwise well-controlled IBD has any role, justification, meaning?
So I would not do that. We do not do that because, there is many reasons for that. First, C. diff, so I mentioned that 3% of healthy adults have C. diff in their gut. I think that it's probably a strong underestimation. Probably it's much higher, but at a very low level so that we cannot detect it. And in IBD, it might be actually even higher. So if you have a positive test, what are you going to do? You just don't know. So I would not screen for C. diff.
Should we consider FMT earlier in IBD instead of waiting till the second recurrence? I mean, probably this is something not only related to IBD, but in general to all patients with C. diff infection.
So in general, I think that probably we should consider FMT earlier, particularly in patients in whom we already know they have high risk of new recurrence. So elderly patient exposed to chemotherapy and so on. Actually, we wanted to do a study like that to try to identify the patients who are at risk of second recurrence after a first one. Unfortunately, it has not been funded yet, but I think this is needed to identify the patients who are at higher risk. In IBD, I'm not sure, because again, I think that the pathogenesis, of course, there is C. diff, but there is underlying IBD. And I think that when you have C. diff infection, you have to focus on the IBD also. So more than doing an early FMT, I would treat C. diff and increase the immunosuppressant and the biologics.
Another question, does FMT have a role for severe IBD? I mean, not only for treating C. diff infection, but for treating IBD, inflammatory bowel disease.
So for severe IBD, honestly, I don't know. We did and we are doing FMT studies in IBD. My feeling is that if you have a very strong inflammation with, deep ulceration and so on, even if you are bringing good bacteria, they are still bacteria. And so basically they are still recognized by the immune system. And for me, it's a little bit like putting, oil on the fire. So for ulcerative colitis, in moderate disease, it might be, it might work. And actually there are studies showing that it is working in a proportion of patients, not in all of them. But in Crohn's disease, in which you have, a much deeper inflammation, transmural inflammation, more systemic disease, and so on, I would clearly not do it. And actually, we did the first FMT studies, first randomized control study in Crohn's disease. And for this reason, we used a very different protocol from the one that have been done in ulcerative colitis. First, we treated the patient with corticosteroids to shut down the systemic inflammation. And then we did FMT. And in this case, it worked. I mean, there is positive signal. Although it is a very small study, there is positive signal. And importantly, we did not see any adverse events. While in previous experience, not in randomized study, but more in case report, it was reported that in Crohn's disease, if you do FMT, you will have fever, translocation, and basically bad outcomes.
We have time just for one or two last questions. What is the recommended diet and nutrition during C. diff infection? Any tips on management for patient during recovery?
So during the active phase, you have to remove fibers. This is the common what we are all doing when you have diarrhea. But in the recovery, of course, you want to stimulate your microbiota, and you should try to eat fibers.
There are some other questions about the use of probiotics. Which one is the best one to be used?
So what I can tell you is I'm using, when I give antibiotics, especially if it's a relatively long antibiotic treatment, I very frequently use Saccharomyces boulardii.
This is what they suggested. So you are in line with the audience. Good. And there is a final question about the case you presented. In the patient case, what factors do you consider to pick when you have to choose an anti-TNF versus steroid in addition to antibiotics? Good question.
So in the case I showed, the patient was already under azathioprine, and despite this treatment, he experienced CDI and flare, meaning that this treatment is not enough, even as a maintenance treatment. So if you give only corticosteroids, you will of course treat the flare, but then you will come back to the basal level and probably to an undertreated state. So that's why in this case we upgrade the treatment with something more powerful.
Thank you, Harry. I think that we have to finish, otherwise we will never stop. And it's 5 o'clock. So thank you a lot for your talk and for your answer. And I have to give my regards again. Thanks to Ferring Pharmaceutical for supporting this activity. And I hope you will be with us also for the next meeting, the next webinar that will be on May 31st for talking about pathogenesis of CDI. Hello, everyone, and have a nice evening.
Thank you very much. Bye-bye.